So I'm here at Zion Massage College to teach at Rebecca's school, and she had a little hoverboard accident and it landed on your back, but it worked its way up through your neck and spine, and now you're feeling it all the way through your traps, levator, scapula. And since we're teaching a massage conference, most of the therapists would be working SCMs, scalenes, clavicular rib space, things like that. But if you look at Rebecca's head, it's all shifted. So what I see, and what you should be seeing, is that the C1 is translated to the left. So that's going to cause a joint problem. We're going to do some positional release of the ligaments, and we're going to get this to translate right and left. Like if you tried to do the Egyptian thing, your head would only, like if you bring your head side to side, it's going to side tilt. So it should just translate right and left.
Yeah.
So we're going to do that, but this is an example of what they're going to see this weekend in class, Rebecca, because we're going to do neck, shoulder, and arm, but we can't do neck if we don't do where it started. So Rebecca has a pelvis that's slightly anterior. So this is off, so that's going to work its way through neck, back, and spine. This is a result of the back injury, and that's what we're going to show you how to treat when we get on the table, is not just to go to right where the symptom is right now, because it's moved from your pelvis into your neck. So what we're going to do instead is we're going to go to the pelvis, look at how that's affecting the lumbar spine, the thoracic spine, the C7, T1, and how these muscles are firing to try to level your head. So we're going to get Rebecca on the table, and we're going to do a little pelvic work, a little ascending spine work, and then we're going to do some really good neck work. And probably about 5 or 10 minutes, we'll get rid of your neck pain. Cool.
I'm excited.
Cool.
Okay.
So in the healthcare system, when someone comes in for neck pain, they're expecting us to go work the neck and the muscles of the neck. But what I like to do is look at the kinetic chain and check that Rebecca's ankles are naturally dorsiflexing and plantar flexing, everting, inverting. This one's got a little bit of a subtalar joint fixation, so I'm just going to do some positional release of the ligaments. And then I'm going to just reduce this increased joint space and push the talus. Now bring your foot up, and there's a little bit better dorsiflexion, plantar flexion, eversion, inversion. I check for tibial torsion, which you don't have, but you have a pelvis that's rotated. Your right ilium is rotated anterior, your left ilium is rotated posterior. So what that would do is that would twist the spine. So that's going to affect your lumbar, that's going to affect your SI, that's going to cause ligaments to refer around your sacrum. So basically what we're going to do with Rebecca's iliums is there's 2 iliums, and I want to keep this simple. This ilium and this ilium are spread apart away from the navel, then pulled back together. When you outflare the iliums, basically what you're doing is you're relaxing the ligaments around the sacrum. When you inflare the iliums, and Rebecca, if you can just put your hands on the outside of my hands, and now rotate your iliums back and forth. And when you're walking, Rebecca, this is what your body should actually be doing. This is called the spinal engine. And so we're going to take that anteriorly rotated ilium, and now your ASIS is even, which means your PSIS is going to be even, which means we can move up, and then you're rotated this way, Rebecca. So your lumbar has to rotate back. So we're going to do a little bit of rotation this way to get the lumbar to not counter-rotate. We're just going to check your shoulders really quick. There's a little bit of supraspinatus impingement. So we're just going to work middle deltoid and drop the humeral head a little bit, and that'll allow me to stretch pec minor, and there's no more impingement in the shoulder. So basically it's so simple. You're just checking joint function first. So this one, now this one is the one the clavicle wasn't moving on. So this is more than an impingement. This is a clavicular rib space. So when I do this on Rebecca, and you're going to put your palms up, just raise your arms up to your ceiling. This sternum is raise them up to your ears, I'm sorry.
Oh, sorry.
This sternum is dropping, this one's not dropping. So Rebecca, you're experiencing some numbness, tingling, paresthesia. So what holds bones together is ligaments. Sometimes I get accused of doing joint mobilization, but what I actually am doing is I'm relaxing the ligaments that hold Rebecca's clavicle to her sternum. And then what I'm doing is I'm elevating the clavicle to access the subclavius muscle. And then what I'm going to do is I'm going to take and go on the first rib and just take a deep breath. And as you exhale, I'm going to decompress the first rib. Now bring your head into lateral flexion towards me. And we're going to stretch middle scalene, and then go ahead and take a deep breath. And as you rotate your head to the right, come back towards me and anterior scalene. And that's important to increase clavicular rib space in here for thoracic outlet conditions. Now we're going to move up into Rebecca's neck. And one of the things you're going to see is when I check her head, her sternum is really, this is the sternum, and this is she's so far translated to the left. So I want to show you what that means. And Rebecca, what I'm going to show you, what that means to you, is that this C1 has translated and is fixated to the left. So it's pressing on arteries, nerves, and blood vessels. It'll affect your thinking. It could cause neurovascular migraine headaches if it's left untreated. So we're going to do muscle energy work. I'm just going to go here. You're going to push left like the Egyptian thing, and I'm going to translate you out of that fixated position, and it's just muscle energy work. So I come under here. Here's the mastoid process. Here's the transverse process of C1, so my hand will be right here. This is how I teach in the class too. I show them how to place their hand properly. Rebecca's going to push left, and then I'm just going to get that to translate. So I'm going to find that transverse process, gently push your head to the left like you're going to do the Egyptian left, and relax. And then I'm now relaxed. I'm going to lift the occiput, and I'm going to translate you to the right. Now let's check right and left translation. Still a little bit fixated. So push left again, Rebecca. 5, 4, 3, 2, 1. Relax. Now when I lift the occiput, now it's moving. There we go. Now do you feel? You can see the translation now. So now Rebecca can translate right, left. So now if these joint functions restored, now it's really easy. Now we're going to get into the massage part. Basically, we're going to take some lubricant. We're going to do a little bit of SCM work. And I'm just going to do real gentle. I'm just going to grab the SCM, slowly rotate like it's a big rubber band. And I'm just doing a myofascial approach to the SCM. So I'm grabbing the sternal head and the clavicular head. And I'm doing left rotation. Now, in most massage schools, you learn that the SCM is attached to the mastoid process, but they actually continue around the suboccipitals on the edge of the occiput. So what the SCMs do, Rebecca, is they actually jam your occiput. So it would actually jam C1 to produce restricted rotation over C2. So when I work the SCM insertion point, I start to stretch the suboccipitals and lift the occiput. A lot of people are really good at working the muscle belly, but a lot of people aren't doing good OA joint decompression. They're not working around the mastoid process and lifting the occiput. So again, I'm just going to go up this lamina groove, work this right SCM. But the most important part is what you're going to see here is that we're going to start lifting that occiput off of C1 so it can better rotate over C2. And then what I'm doing, Rebecca, is I'm just going to close those posterior facet joints because they're kind of stuck open in the back. So I'm going to take C6, close it onto C7, C5. This is a good time to ask the client a question, anything you want them to say yes to, because her head can only go in that direction.
That's right. Yes.
So we're just going to do that. We're going to restore that normal lordotic curve of the neck and decompress those nerves in there. And then we're going to kind of scrub out each lamina groove. My left finger pads are in her right lamina groove, and then my finger pads of my right hand is in her left lamina groove. The other thing we're going to do is facilitate better opening and closing of the cervical facet joints to increase lateral flexion. So basically, through good soft tissue work and through good positional release of the articular ligaments, we can improve facet joint function. We can restore that curve. We can do techniques that will work with the soft tissues and the ligaments to facilitate better closure of the posterior facet joints. And then I can still feel a little bit of translation on C1 right there. So with 10% of your strength, just push your head left, Rebecca. 5, 4, 3, 2, 1. Now I'm going to lift the occiput with this hand. I'm going to slide you out of that. Now, there it goes.
Yeah, that's better.
Now we can get translation in there. And then we'll just come into that cervical curve again. And then we're going to get and work those suboccipital muscles, rectus capitis posterior major, minor, oblique capitis superior. Anything that's tight back there, just start to pin and stretch that tissue in the back. And a great way to get the occiput to lift is you put a little bit of pressure on the frontal bone and lifting the occiput in the back. Now I want you to feel an enhancer, Rebecca. When you look down with your eyes, it'll enhance the stretch of those suboccipitals. The optic nerve sends a message to the suboccipitals to neurologically inhibit through, when Rebecca looks down with her eyes, I can get a better stretch of those suboccipital muscles, which means we can get better OA joint extension.
Same way that hoverboard moved.
Exactly. But the hoverboard moved you to this way, Rebecca. Now I'm taking you out of what the hoverboard did. And so when you think you're a 5th degree martial arts and you're the master of the hoverboard, this is sort of the karmic experience that happened when you're over 30.
Oh.
but don't ever give it up.
Thank you.
I remember someone saying, well, why do you ride your bike so much? Because it's my passion and it's my time in nature, and I like being a child. And it produces positive endorphins. So this
does.
And then we're going to get into that levator scapula in there, because you were having some stuff in that shoulder. And which arm did you get the numbness in? So let's do a little bit of clavicular work. We can create a little bit of a lymphatic pump here, just drain that lymph a little bit. Move this clavicle off that first rib. Now let's recheck that clavicular movement. So palms up. I'm going to bring this product out of the way. And now go ahead and raise your arms up again, Rebecca. Now can you feel those are both dropping now? So now when the clavicles drop down into the sternal notch, we don't have as much TOS. And now I'm going to do one last thing. I'm going to really show you an amazing anterior-middle scalene release without actually working the scalenes. If you can grab that first rib, now watch what happens when Rebecca takes a deep breath. The rib will come up, so let it. And Rebecca exhales. I drop that first rib off that clavicle, and then I stretch middle scalenes, but you got to keep the rib anchored. If you don't keep the rib anchored, they're going to decrease clavicular rib space. Another deep breath. And this time rotate towards me, and then we bring anterior scalene into it. And then we'll just finish it up. I always like to finish up a neck treatment with something that connects everything back together, something that calms down the sympathetic stress, something that reduces upregulated stress. And that could be anything in life experiences of stress, and feel the difference in your translation now.
Yeah.
And now we go back here. On some people I work this, it's really called putting their head on straight.
Totally. I can feel it. Thank you.
But do you feel how that occiput can lift now? And how that, now rotate all the way to the right. You shouldn't have any, do you have any restrictions or pain on right rotation?
No, just a little bit through the
Okay,
arm.
so let's go right through and grab that levator. Comes off that scapula. Now, one of the things the students are going to be learning is scapular repositioning. Scapulas tend to be upward rotated. So if the scapulas aren't downward rotated, by stretching those upper traps, it's real hard. So I'm going to have you just put your hands under your hips. And I'm going to go ahead. Now when I treat your levator, your scapula is in a better position for better myofascial outcomes in levator. So that gets rid of some of that upper trapezius.
Yeah, it really does.
Levator scapula work in there. And now that the hands are anchored, your scapula is not coming up when I work those muscles. And then we'll just go back and check the finishing touches. Do you have the normal lordotic curve in the neck? The occiput's lifting a whole lot better off of C1. And now do the Egyptian thing where you go left, right, without side bending. Just go this way. And there we go. Push left and relax. And there it goes. There we go. Now we've got good translation. Now, if you look at the difference of the position of her trachea from the sternal line into the nose and eyes, now basically we've got the whole head in neutral. So I'll just finish with a little bit of spinal decompression, because that just feels good. I like to do that a few times. That feels really good. And just look down with your eyes and see how much easier it is to stretch those suboccipitals in there. Now rotate right and rotate left.
Much better.
And side bend right. And side bend left. And flexion extension's better. Good.
Thank you.
Let's get up and see how you feel. Now before we finish, we'll face the camera, turn your head all the way to the right and all the way to the left. And then raise your arms. You should be able to touch your ears with both arms. There should be no impingement in those shoulders. So just a quick review of what we're going to be teaching the students this weekend.
Great. Thank you.
You're welcome.
For information on becoming a licensed massage therapist, visit zmc.edu. For information on continuing your education in massage therapy and bodywork, visit studyhealing.com. If you like this video, don't forget to subscribe.